Thank you, sir. We have our next speaker, Dr. Gobu, MD in Internal Medicine, DM Cardio, Senior Consultant Cardiologist, Gleneagles Global Health City, Chennai, will be talking about PCI.
Good afternoon, everyone. I will be talking about PCI in diabetics. So, what favors PCI in diabetics? When do you favor PCI? See, there is clear indication for PCI in diabetics also. Single vessel disease, double vessel disease with non-proximal LAD disease, in acute coronary syndromes, cardiogenic shock. These are areas where there are clear indications for PCI. The gray zones are where there is triple vessel disease and left main disease. This is the area where whether PCI is suitable or not. So, this is where the other studies come into play. So, basically we have three forms of treatment, that is optimal medical management, CABG and PCI. So, as Dr. Murugasundaram sir has said, that PCI targets only the site specific region, that's true. Whereas CABG targets site specific and some non-site specific regions also. Non-significant lesions are also targeted. So, because it bypasses, so some lesions which develop later also can be tackled. OMT is going to take care of both significant and non-significant lesions as well. So, this is now with the current standard of treatment, we have so many drugs that is also going to play an important role. Why I am saying these drugs are important? Because the trials, most of the trials when done, we didn't have enough drugs. Now we have newer antiplatelets and SGL2 inhibitors. So, these things also may play a role in the difference between PCI and CABG group. So, first, in this Freedom trial, 1,900 diabetic participants were randomized. This trial clearly showed that the primary composite endpoint of death MI was significant in CABG group, significantly low in CABG group, but the incidence of stroke was higher in the CABG group. But the important thing is, this was done with the first generation stent. So, after that there was further refinements in the stent. So, this was not the current standard of treatment. Current standard of treatment is we use the second generation stents, or even now the third generation stents have come, which may behave differently. So, that is one thing. So, the advantages of CABG in the long term, these are the majority of trials have shown that there is a reduced risk of repeat revasculation. This is one thing which is consistently proven. Then there is a reduced risk of MI in some trials, like the Freedom, Noble and Best trials showed that there is reduced risk of MI and reduced risk of death in few trials, that is Freedom and Excel. But if you see the short term disadvantages of CABGs, there is increased risk of peri-procedural events, even death is there, MI, stroke, renal failure, bleeding and requiring more transfusions, infection, prolonged intubation and prolonged recovery. And all these things are very, very less in PCI group, or almost very rarely we encounter such situations. So, how to reduce the gap between PCI and CABG? So, because of when you put a stent, there is problems related to the stent itself, and there are problems related to non-stented area as well. So, the stent related area are restenosis, stent thrombosis and neoatherosclerosis. Whereas in non-stented events, there may be some lesions which we might have considered non-significant, but actually they may be significant. So, it's not completely treated. So, that is the other problem with this. So, if you see the stent related events, that we can manage with our current second and third generation stents. Then predominantly use imaging and physiology guided PCIs. And adjunctive tools in case of calcific lesions, use of ROTA, IVL, the OPN balloons may make a change. And advancement in the pharmacology also may make a difference. And for the non-PCI lesions, non-significant lesions, other lesions, we have to rely on medical management. So, that is this. So, now there are one or two trials where the CABG was used with newer generation stents. And in the first, this is a registry which has more number of patients. This study is a very important study where the comparison of death, stroke at the end of 4 years was almost equal. So though there are more numbers of lower deaths in CABG group, but it was not statistically significant. So this is a NOI's registry, New York State Registry. Similarly, you see that the myocardial infarction rates were lower in the CABG group. But if you analyze that, if you see that in the group of PCI patients who have undergone complete revascularization, the comparison was almost similar. The rate of MI was similar in between PCI and CABG in the group whom complete revascularization was achieved. So the important thing is where we achieve complete revascularization. Similarly, this is about the 3 randomized controls from BEST, Excel and Noble. If you see the 30-day outcome, PCI scores over CABG. Whereas in the long-term outcome, there is difference in the rates of major advanced cardiac events, but it does not achieve statistical significance. As you also know, this is the freedom trial where you see, if you see the same point which I have already highlighted, that when there is complete revascularization, the outcome is similar between the stented group and the CABG group. So freedom follow-on and syntax, these are the 2 studies which use the second generation stents, the first generation stents. So in freedom follow-on, it's very clear that CABG leads to lower mortality than PCI. Whereas in syntax, there is no significant, this is a syntax follow-up, syntax follow-on trial, there is no significant difference between the PCI and CABG. Even in diabetics, you will see that there is no significant difference in this. Also, in the BEST trial, it was prematurely stopped because the enrollment numbers were less. So the numbers were not too much to really contribute to the study. So this is also, you see in the BEST trial, this is the impact of diabetes also, you will see that it is not that very significant. So the mortality benefit of CABG or PCI in few trials should not be a compelling reason for us to choose CABG. So we have to go ahead and see the other aspects. So if you see the extension of survival, this is the freedom follow-on and the Excel trial, there is not significant benefit. If you see the extension of survival, if you extrapolate and see, so if you go for CABG at the end of 8 years, there is extension of survival by only 3 months. So for that 3 months, whether you have to really go for CABG in all the patients is a question. That's what. From a patient perspective, if you ask the clinical trialists, they will say death is much more worse than stroke. But if you ask a patient, he will say stroke is as equal as to death. So there is much focus must be also laid on the stroke as well. So coming back to this, the important thing which as cardiologists which we must also realize is that our newer generation stents optimizing PCI outcomes with perfect technique may definitely improve the outcome along with optimal medical therapy. So as sir has already asked for a FAME-3 trial, FAME-3 trial is at the end of 1 year, it has shown that PCI, FFR guided PCI is not inferior to CABG. But 1 year is relatively short term to comment. And FFR measurement was not mandated in the CABG arm, but that doesn't make a lot of sense. But intravascular imaging was utilized in only 12% of the cases. So that is the important thing. The outcome of PCI might have been altered because of that. So we have to rely more on imaging in the current. So imaging and physiology guided PCI will definitely change the outcome of PCIs. And as of now, the completeness of revascularization, that is how many PCI patients underwent complete revascularization, is not available. So it is premature to say that FAME-3 is in favor of CABG. So if you compare the risk of short-term death and stroke and the risk of long-term repeat revascularization and with marginal increase in death, we have to see the patient preference and the particular individual patient. So in conclusion, I can say that there is not much mortality difference between CABG and PCI in major trials. Imaging and guiding physiology guided PCI will definitely improve the outcomes. Use of other adjuncts for PCI will improve the outcomes, and decision about CABG versus PCI depends on, first point is the ability to completely revascularize and weighing the short-term risk of death and stroke with CABG and with the long-term risk of repeat revascularization and death, and patient preference also matters. Thank you.
Thank you. That was actually a very nice debate from both Dr. Murugasundaram and Dr. Gobu. Both of them put forth their points very well in favor of PCI or CABG. I think the differences are obvious. PCI patients generally do prefer because it is less invasive and they are able to get back to work sooner, while CABG is a much more debilitating procedure. But, and of course, with respect to the complexity of the lesion, the number of vessels involved, if it's a single vessel or double vessel disease, as Dr. Gobu has pointed out, PCI is definitely going to be advantageous, even in the diabetic. But when it comes to triple vessel disease, more complex lesions, if the syntax score is higher than 33, or if the left main is involved, these, again, as he said, they are gray areas, where CABG has always been ruled in favor. CABG always has conferred an advantage in all these lesions. But the point that we have to consider now is this drug-eluting stents are improving, PCI techniques are also improving, including the fractional flow reserve, which probably reduces the adverse events after PCI. They are able to cannulate only the lesions which are really obstructive in nature. So, in conclusion, I think it has to be an individual-based decision, particularly in these gray areas, and it should also be a team-based decision as advised by the AHA. The AHA prefers that all these gray areas should be addressed by a team of cardiothoracic as well as interventional cardiologists, and the best thing for the patient has to be determined. So, thank you both for a wonderful debate.
Thank you.
Dr. Murugusundara Pandian R. and Gobu doctor for actively participating in the debate. Right now, we have a small talk by Dr. Joseph Rajendran, US FDA.
Yeah, thank you, the organizers. And I was not expected to be giving you this small talk or anything, but I won't take much of your time.